I want to welcome everybody. Thank you so much for being here tonight at this month's Understanding ADHD Speaker Series event. It's hosted by the ADHD Empowerment Meetup Community and the nonprofit Children and Adults with ADHD, or CHAD for short, of San Fernando Valley, Los Angeles. I'm Suzanne Sophos, our executive director. I'm also an adult with ADHD and mom to a third grader with ADHD. CHAD has been hosting this speaker series for the last 5 years, bringing experts on the topic of ADHD directly to the community. This event is just a part of our work to educate, support, and advocate for adults and children who are living with ADHD. We also offer online peer support groups for adults with ADHD, a peer support group for young women with ADHD, and one for parents of ADHD children. All our groups are facilitated by our dedicated volunteers, and all of our work is funded by donations. Because we want to ensure that everyone who needs ADHD education and support can receive it, there's never a fee to attend our events. However, we are a nonprofit organization and our survival really does depend on donations and membership fees. So we ask, if you're able and you find our work worthwhile, that you consider making a $5 or $10 donation tonight to help support our work. And we'll have one of our volunteers post the link in the chat so that you have the link to make a donation if you'd like. I'd like to share just a few quick kind of guidelines. We've all done a lot of Zooms in the last couple years. So most of these will probably be familiar to you. Just for privacy reasons, we recommend that you set your Zoom name to just your first name and your location. So not using your last name, but it's definitely up to you. We do ask that you keep your audio muted when you're not speaking. This just helps us ensure that whoever's speaking can be heard, because we do have a good deal of RSVPs for tonight's event. We encourage you to use the chat feature at any time throughout the meeting to share your thoughts. Even when the speaker or others are talking, we find it really adds to the conversation. You guys can share with each other. And we will also be doing a moderated QA at the end of the evening. So what you'll do is you'll type your questions directly into the chat, and our moderator, which will be me tonight, will share your questions with the speaker, and we'll take as many questions as time permits. So you can go ahead and at any time throughout the meeting that you have questions, you can type them into the chat and we'll scroll through and kind of record them so that we can ask them toward the end. Before we dive in, we just want to start off with a brief evidence-based overview of what ADHD is and how it impacts individuals. That way we're all on the same page before we get started. ADHD is a lifelong neurobiological disorder. It impacts brain function in a way that impairs executive function, delays social emotional development, and impairs our self-regulation. So rather than thinking of individuals with ADHD simply as having too much energy, which some people call hyper, or too little energy, which some people call inattentive, or worse, lazy, a hallmark of ADHD is actually impaired self-regulation. So trouble getting our bodies and minds in the right frame for the task at hand. So sometimes, sure, we may have too much energy, more than the situation calls for. This can be a hyperactive state. Maybe we get too focused on a project and forget to walk away to eat or use the bathroom for hours. You may have also heard this called hyperfocus. Maybe we get excited about a new idea and ramble on to a friend without realizing we never let them speak. Same. Then there are times when our bodies and minds regulate with less energy or attention than a situation calls for. This is an inattentive state. Maybe we zone out while we're taking a test or having a conversation with someone on a topic that doesn't really interest us. It can also show up as trouble getting started in the mornings or getting motivated and organized to do something challenging like paying bills. Individuals with ADHD can veer toward hyperactive or inattentive, or be a mix of the two. For people with ADHD, getting our bodies and our minds to cooperate and serve up just the right amount of attention and focus for the task at hand can be extremely challenging. Studies show that if ADHD is not diagnosed and well treated, ADHD-related challenges can significantly decrease life expectancy, which is really hard to hear, but it's really important and good for us to know. The good news about that is that studies show that life expectancy and outcomes are dramatically improved by two things: a proper diagnosis and a lifelong holistic treatment plan. A holistic treatment plan includes a combination of ADHD education, which is what we're all here for tonight, skills training, medical treatment, and peer support. And then this slide is pretty meaty, so I usually don't go over it in too much detail. I like to say that it's available on our meetup page, so you can take a look at it there. But I do want to just kind of give an overview that understanding ADHD also means understanding the brain's executive functions, because those are both delayed and impaired in those of us with an ADHD diagnosis. And executive functions are the things that help us manage and regulate pretty much everything we do in life. So our planning, our decision-making, learning, judgment, emotions. This particular model that we're showing is based on Dr. Thomas Brown's model, and I encourage you guys to look him up. And I highly recommend doing a deep dive on executive functions, because it really will help with understanding your ADHD. And the good news about executive functions are they're not just static. So it's like a muscle, and you really can improve them. Along with medication and other treatments, things like executive function coaching and learning how to strengthen the skills can be a really important way to improve your ADHD. So tonight, I'm so excited and pleased to welcome Dr. Carolyn Lentzsch-Parcells, a board-certified pediatrician and the owner and president of Girls to Women and Young Men's Health and Wellness in Fort Worth, Texas. She has ADHD herself and is a frequent and wonderfully engaging speaker on the topic of ADHD medication for CHAD, ADDA, and many other respected evidence-based ADHD organizations. Tonight, she will help us simplify the complicated topic of ADHD medication and help us better understand treatment options. As I mentioned, we'll follow the presentation with a moderated Q&A, so please feel free to type your questions in the chat throughout the meeting. Welcome, Carolyn. We're so glad that you're here. I'm going to stop my share so you can share your slides. And I'm going to unmute you. I think you're muted still. There you go.
There we go.
Yeah.
Okay. Yeah. Okay. Thank you so much. And I love that education you did at the beginning. I'm going to have to check some of that out, because I really like the summary you did.
Thank you.
So, excuse me. Let me get my slides up and rolling here and get that shared for, oop, fiddlesticks. You'd think at this point we'd all know how to do this smoothly, huh? Good gracious. Here we go. There it is. All righty. Can y'all see it? You can see my slides? Okay, fantastic. If you want to put my face in a particular corner, the lower left is where my face was when these slides were created. So it won't get in the way as much if you put me there, but feel free to do whatever floats your boat, okay?
We usually keep it open for everyone in case anybody wants to talk
works
later. So I think
that
you're
works
over at the right.
Whatever works. So as Suzanne said, my name is Dr. Carolyn Lentzsch-Parcells. I'm a board certified pediatrician. I practice what's called adolescent medicine in Fort Worth, Texas. So that means I take care of kids about ages 10 to 25-ish. I say ish because I actually do see kids as young as 6, in particular for things like ADHD, behavioral issues, etc. And I've got some 28-year-olds, because who am I going to hand them off to? Right? So I well, I don't necessarily personally take care of people with ADHD that are further into adulthood. I do have quite a bit of experience and knowledge in kind of ADHD and medication throughout the lifespan. Okay. So let's get into it. As Suzanne said, in addition to being a physician, I do have ADHD as well as a learning disability myself. So this topic in this community is very near and dear to my heart. I've had my own challenges with my ADHD and with learning disabilities, but also frankly with finding a treatment plan and treatment regimen that works for me. So I know both from the physician side, but I also have perspective from the patient side and also from the parent side. So that's kind of what I bring from a perspective standpoint. So, excuse me. I have my lovely little objectives here, but you know, some folks, when they do the academic, when I do these academic talks and things like that, they really want to see these objectives. To me, though, the real point is just simply that my hope for you by the end of this talk is that whether or not you are the parent of somebody with ADHD, you have ADHD, you work with people with ADHD, whatever you're coming to this, whatever perspective you're coming to this with, that you will walk away with a better understanding of the medications and hopefully a better, more of a comfort level with the medications as well. So let's dive into it because I got a lot to get to. I'm also going to apologize ahead of time if I do any coughing, sneezing, or etc. I'm a little under the weather, so forgive me. So before I get into the actual medications themselves, I want to talk to you a little bit about why we even use medication in the first place for ADHD. What does it do? Why do we use it? Well, first of all, as Suzanne actually kind of touched on, is that research, right? We have reams and reams of research showing that a complete treatment plan, which often does include medication for a lot of people, really improves outcomes for people with ADHD. Excuse me. In particular, the stimulant medications, although I am going to touch on some of the other ones. We know from pretty extensive studies that medicine, as part of a complete treatment plan, can improve optimal outcomes for everything from decreasing rates of depression, anxiety, substance abuse, school failure, work failure, accidents, improving social development and relationships. As Suzanne alluded to, we actually also now have research, largely from Dr. Russell Barkley, suggesting that that optimal treatment of our ADHD also improves I'm sorry, hang on just a second for me. Okay, we're good. Sorry about that. Thought I had a kiddo coming down. We're good. So as I was saying, we also now have research that shows that treating our ADHD may improve our lifespan, as Suzanne touched on. And really what that comes down to is the idea that if we are optimally managing our ADHD, we are much better able to take care of ourselves on the whole. We're better at initiating healthy lifestyle changes and maintaining those changes. We're more likely to make that doctor's appointment that we need to make. We're more likely to keep up with our blood pressure medicine or our diabetes medicine. In addition to that, we are less likely to have accidents, as I mentioned before, and something we often don't like to talk about but need to, it also decreases risk for suicide. So all of those things together are why it is so important that we have an optimal treatment plan for us, regardless of what all that entails and whether or not that includes medicine. So coming back to the medicines, we are still learning a lot about ADHD, of course, and we're also learning about these medicines. But we have had the stimulant medications around, and they have been in use since the 1930s and 40s. Okay, that's when they were first used for ADHD. So these are not new medications. There's new formulations, and there's some other non-stimulant medications that are new, but the actual molecules themselves, the actual medications themselves, are not at all new. Now, with that said, okay, great. So what do we know about them, right? So, excuse me. We know two of the brain's main neurotransmitters, dopamine and norepinephrine, are pretty key in ADHD, and they play a pretty significant role. Okay, so what do these neurotransmitters do? Well, they are chemicals that are produced by the cells in the brain to allow the brain cells to communicate. Okay, and we know that dopamine and norepinephrine, like I said, are pretty key transmitters in ADHD. Either we're not making enough of them, we're not producing enough, we're not using them correctly, things like that. Now, dopamine and norepinephrine control things like attention and alertness and motivation and things like that. So you can see how they would play a pretty significant role for us. The medications, stimulant medications in general, but even some of the non-stimulant medications really focus on increasing available dopamine and for some of them norepinephrine as well. Now, that is not to say that these medicines are a magic bullet or a cure-all, okay? But I hope many of you would agree with me, we don't need a cure, right? We do need help. There are certainly challenges that come along with having ADHD, sometimes significant challenges that come along with having ADHD, but there are also significant gifts, right? There are the aspects of creativity. We tend to be very passionate and enthusiastic are the words I like to use, as opposed to obsessive and energetic, right? We have attention, there's this common kind of thought that we don't pay attention to details. No, wrong. The issue is that we notice everything. So it often makes it hard for us to narrow in on the details that we're supposed to prioritize or that other people think that we should prioritize. But we often catch details that other people miss. Honestly, this is one of the things that I think is one of the most important gifts for me in doing what I do, because I can catch details in somebody's history or story or things like that that somebody else might not have caught because they weren't catching all the details. We can be incredibly wonderful problem solvers. We may do it differently, but that often is part of what our gift is we approach problems in a different way, and we may see solutions that other people don't see. We tend to be very entrepreneurial and willing to take risks. We oftentimes seem to think this impulsivity and risk taking is completely a negative thing. It's not. It's not. It has its moments for sure, where it's not the greatest choice, maybe. But being willing to take risks is also the things that enable us to be entrepreneurial, to start new things, to be creative, to solve these problems. So when we're talking about our treatment plan, when we're talking about medications, these are the things that we also don't want to, as a result, take away, right? So I always tell folks, pills don't build skills, but they sure as heck help us use them. We still have to build those skills. We still need to figure out how to do things differently because our brains work differently. But actually Russell Barkley, again, one of my favorite quotes of his is that ADHD is not a disorder of knowing what to do. It's a disorder of doing what we know. That one hits home for me. Because how many times have, any of us with ADHD sat there and we know the skill. Maybe we've even practiced the skill, and a situation happens and we don't use it because of that impulse control, right? We don't have that split second frontal lobe speed bump, as I like to call it, to stop and go, okay, how am I going to handle this issue? Oh, right, that skill, let me bring that forward. And then what do? We go down what I like to call the shame spiral, right? The medicine in an ideal world helps us to, for one, learn the skills, because it helps us with the attention and focus we need to learn a new skill and store a new skill in our brains the way we need to be able to recall it later. But then it also, hopefully, again, ideally, helps with that impulse control in a way that enables us to pause for that split second, pull up that skill or that coping mechanism or that strategy and actually put it into use. So when I'm talking to my patients about what do we want the medicine to do, what are we looking for, what is the goal here, I like to use a superhero analogy that actually came up with a little 8-year-old boy patient of mine in the room one day. And I know there's a lot of folks in our community who aren't the biggest fans of the superhero analogy. But if you're one of those folks, I want you to stick with me here for a hot minute, because I think I do mine a little differently. But the way I describe it is this. If you think about any superhero's origin story, which of course is big right now, most superheroes, their origin story and the origin story of their powers includes the concept that power was bad or evil or dangerous or abnormal in some way, shape, or form. They feel like they have to hide it or can't control it. Some superheroes just have to learn how to control their superpower and use it for good, not evil. But some superheroes need equipment. I love to use Cyclops. This is the superhero that my little 8-year-old patient mentioned to me when I asked him who his favorite superhero was. And I was like, oh my God, that works perfectly. Because Cyclops has laser beams flying out his eyeballs. Okay. There's nothing he can do about that. He can't change that. It is what it is. that seems like a pretty destructive, to some people, maybe even horrible power to have. So he has to have his visor. Now, this is one of the big keys to me, is that the visor does not take away the laser beams. It does not eliminate them. It gives him the power, the control over when he uses them and when he doesn't. That's what the medicine, in an ideal situation, that's what we're looking for with the medicine, is not that it takes away our creativity, our energy, our talkativeness, whatever it is for you that is your gifts, but that it gives you more control, more power over those gifts to use them to the best of your ability. It gives you control over the ADHD as opposed to the ADHD controlling you. So I'm gonna jump down off that soapbox for a hot minute, and let's actually get into the medications. So the stimulant medications are still the gold standard first line medications for ADHD. Okay. And the reason for that is just the research. The research shows that these are still, even with all of the other medications that we've come across, these are still the ones that the research shows work the best for most people. Obviously, that's not going to be the case for everybody. The stimulant medications, excuse me, in theory, can help with improved attention, focus, staying on task, motivation, organization, impulsivity, hyperactivity, emotional regulation, all the core symptoms really of ADHD, and can help with not just what we call the core symptoms, which are the things I just listed there, but functionality, right? How it actually affects us in our daily lives. Now, there we go. Now it's moving. I was like, what's going on here? There we go. Here we go. Sorry, I'm having some technical issues. There we go. There are two families of stimulants. There are the methylphenidates. Those are your things like Concerta, Ritalin, Jornay, Cotempla. We'll go over some more of those in a minute. Those are the methylphenidates. And then there's the amphetamines. The amphetamines are things like Adderall, Vyvance. There's a whole bunch of new ones. We're going to go over them class by class, but both of those classes have, let me go back here. Both of those classes have the potential in the right person to have these effects. Now, the other thing with all of the stimulants, whether it's methylphenidate or Adderall, is that they can share common side effects. So the common side effects, not all side effects, but common side effects are things like headache, stomach ache, decreased appetite, weight loss, trouble sleeping, increased irritability, anxiety, kind of feeling, the way I describe it to my patients is kind of feeling restless or revved up, but not in a good way. Or the opposite, feeling zombified, blunted, not your usual fabulous self. Some people even have worsening mood or dry mouth. I have tics listed here, but I have it there because it's often gets lumped in with side effects, but it's actually technically not a side effect. The stimulant medications don't cause tics. They can uncover or exacerbate tics that are already there or would have otherwise come to the forefront anyway. Now, that does not mean that you're going to have any of these side effects. The other thing that's really interesting is you could have side effects in one family of medications, the methylphenidates or the amphetamines, and not in the other. But even more interesting to me is, even though I've done this for, I'd rather not tell you how many years, it still fascinates me how the same molecule, so like methylphenidate, in a different formulation or preparation. Love you, night night, babe. Sorry. I'm sorry, guys. Hold on a second. Yes, honey.
Was I usually just asked to add someone on my contacts?
No. No, honey. Can you go talk to daddy about it, please?
No,
Thank you.
he didn't either.
Okay, then don't. Then don't, please. Okay? Love you, night night. Oh, the joys of Zooming from home. Okay, so ADHD moment, lost my flow. Where was I? Side effects, yes. Okay, so what's really interesting is that even within the same family of medications, in a single person, one formulation may cause certain side effects or be less effective, and a different formulation may have a completely different effect, may be more effective, may have fewer side effects. And this is something that I think is actually really important for people to understand, because oftentimes I have patients come to me who have tried one medication. and maybe it didn't work for them, or it didn't work well enough for them, or they had side effects they couldn't tolerate and they stopped, or they tried one medicine in one class and were changed to the other class and that didn't work. And so then they feel like there's no option for them, right? Just because one doesn't work for you doesn't mean the other ones won't. Okay. So I think that's really important to understand. The other thing is that is kind of common amongst all of the stimulants, and that's interesting about these medications, is the way we dose them. The dosage has nothing to do with your size, your age, or the severity of your illness. Okay, the severity of your ADHD. Okay, for everybody across the board, we start at the lowest or one of the lowest doses, and then we titrate or increase the dose incrementally until we reach the most effective dose with the least or most tolerable side effects, or of course, preferably none at all. That would be great, right? And that's how we dose all of these medicines. And that's how they should be dosed in children and in adults. So let's get to the methylphenidates. Both methylphenidates and amphetamines work by increasing available dopamine in the brain. Okay, so that neurotransmitter we were talking about that helps the brain cells communicate with each other, but they do it in slightly different ways. For the methylphenidates, they increase available dopamine in the brain by inhibiting dopamine reuptake by the neurons. What does that mean? Basically, your brain is still producing the same amount of dopamine, but instead of it being taken back into the system, recycled, and essentially thrown away, the methylphenidate keeps it available in the space between the neurons longer so that your brain can use it better and for longer. Excuse me. All the medications in this family, all of them are made up of the same molecule, methylphenidate. Okay, Cotempla, Daytrana, Concerta, Jornay, Ritalin, generic methylphenidate, Metadate, all the same molecule. Okay, the one exception to that is Folklin, and I'm going to circle back around to that in a little bit. The main difference is the formulation. And when we talk about the formulation, what we're talking about is how and when the medication is released. Okay, and we'll talk about that a little bit more in a sec. So there's short-acting or immediate release formulations, and there's long-acting formulations. The short-acting or immediate formulations come in these. I included the trade names. I do not get anything from any pharmaceutical companies, so there you go. I'm just putting them out there so that you know what the names are that are common. And the generic, of course, is methylphenidate. For these, the onset of action, or when they kick in, is about 30 minutes. And they last about 3 to 5 hours, depending on the person. But that can be dependent on how each individual person metabolizes these medications, okay? For all of the stimulants, is another thing that's really interesting about these classes of medications, is they are very dependent on your personal metabolism by your liver of this class of medication. It does not have anything to do with your food metabolism, okay? There are what we call average metabolizers, in which case the medicine lasts about as long as the average that we're mentioning here. There are fast metabolizers whose bodies process the medicine really, really fast, and so the medicine often doesn't last as long for them. And then there's slow metabolizers for whom the medications last longer than expected, okay? That's gonna come back in a minute. How do we use the short-acting or the immediate release medications? We prefer not to use these as the primary medicine for most people unless they're a really slow metabolizer, because if you're using it as the only agent, you have to dose it 2 or 3 times a day. Really? Really? We're gonna remember to take our medicine 2 or 3 times a day. The medicine we have to take to remember to do things like take our medicine. No. No, 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 no. So we prefer to use it primarily as like a booster dose in the afternoon if your primary long-acting medication isn't making it long enough. Or, for example, sometimes I'll use it for folks for whom maybe they wake up too late on the weekends to take their long-acting, but they still have things they need to get done. We might use it there. There's various situations we may use it. And I do have some folks who use short-acting, either again, because like I said, they're very slow metabolizers, or because this is what they tolerate, and they tolerate the short acting better than they tolerate the long acting, and this is just what works for them. And so we deal with it. These formulations come in tabs, chewables, and liquid, by the way. So if you have somebody who can't or really struggles to swallow pills, there are other options. As I mentioned, metabolizing, really, I can talk today. The metabolism of these medicines can vary. One of the positives of the short-acting or immediate release is cost. These are, generic short-acting methylphenidate. Not only is it well covered, but it's very inexpensive from a cash standpoint too. So that can be a deciding factor for some people and a benefit for some folks. One of the big negatives, though, of these is it is the short-acting formulations, both of methylphenidates and of amphetamines, that have the highest risk for diversion or misuse compared to the long-acting formulations. Diversion is the term that we use for these medications going to people to whom they are not prescribed or who don't have ADHD. And yes, I say or, because just because they're going to somebody who it wasn't prescribed to doesn't mean it's not somebody who has ADHD and either hasn't been diagnosed or doesn't realize they have it, but it's still an issue, right? And it's still something we need to monitor and avoid. So long-acting formulations. So of course, one of the ones that most people really, have heard the most of is Concerta, but there's also a bunch now, right? The good news is we've got a lot of options. The bad news is we have a lot of options. The good news is we have stuff that has to be swallowed. We have stuff that can be sprinkled. We have liquids, we have chewables, you name it, we got it. We got different flavors. Although who thought Quilivant, which is the liquid, should be banana flavored? I have no idea. They clearly did not have a child with ADHD. That is all I'm going to say about that. So I do want to kind of tell you overall with these medications, because obviously going through every single one, not really an option in this period of time. In general, with the long-acting formulations, like I said, they are the preferred kind of first line option for managing ADHD across all ages. The dosing is typically, hopefully, once a day in the morning. I usually tell my patients before 10 a.m. until at least we know how long it's working for them. The onset or when it starts working can be anywhere from 20 minutes to 60 minutes. This is dependent on the person. It's also dependent on your breakfast. The larger the breakfast you have, the more fat and protein that you have, which, by the way, I am a big fan of high protein breakfast for ADHD people, but it does mean it's going to take a little bit longer for your medicine to absorb and kick in. Most of these medicines are going to last anywhere from 8 to 12 hours. We do now have some formulations that are supposed to last 14 plus hours for average metabolizers. I'm going to touch on that in a minute. And again, it depends on the formulation and it depends on the person. One of the things with the long-acting medications that we don't see as much with the short-acting medications that I think is important to point out, because I've seen a lot of folks kind of have this and not really understand what's happening, is the fact that when folks are coming off the long-acting formulations, not everybody, this doesn't happen to everybody, but for some people, they can get some significant emotional lability. Okay, what we mean by that is things like being more tearful, maybe not even knowing why, or being more irritable or more short. For some people, it's pretty, and it can be about an hour to 2 hours as they're coming off the medicine. For some people, it's not a big deal. It's pretty subtle. Once they know what it is, it's not a big deal and they can manage it. For some people, it can be significant enough that either we need to change the medication, or this is another scenario where sometimes what we'll do is add an afternoon booster of the short acting to smooth that coming down off the medication. And for some people, that can be a real game changer. So a couple of the long-acting methylphenidates that I want to point out, because they're a little special. The Concerta. Concerta is a unique one because of its release system. So name brand Concerta looks like a little Tic Tac, okay? That one has what we call an osmotic release, which mimics approximately about a 3 times a day dosing, but it's smoother than if you were actually taking it 3 times a day. Typically lasts about 12 hours. But one of the key things about Concerta that's important to know is that this is one of those cases where not all generics are created equal, okay? If you get a generic methylphenidate ER, is what it'll say, that looks like a Tic Tac, you have the osmotic release system. If you get the one that looks like a circle, It's not the same. Now, there are some folks who will tell you, you can only, only do the tic tac, only do the tic tac, only do the tic tac. It depends on the person. So I just kind of let my patients know, pay attention to which one you get and how you respond to it. If the circle is covered by your insurance or it's more affordable for you and it works for you, okay, fine. If it's not working for you, we may want to specify on the script that you need the tic tac one, not the circle one, and see if you respond better. And certainly if they go from one to the other, if the pharmacy fills one version, then fills the other version, that can, again, for some people, it doesn't cause much of a difference at all. For some people, it can cause a very major difference. So I do think it's important for people to be aware of that. Jornay, this one's fascinating. This is one of the ones that, every time a new ADHD medicine comes out, I'm like, really? Do we need another one? We don't have enough. This one is different. This one I didn't feel that way about. This is what we call a delayed extended release, and it is a unique delivery system. I think they're working on trying to do this for an amphetamine preparation too. I'm not positive on that. But what it is you actually take it at night and it delays release for 10 hours. It releases less than 5% of the medication overnight, which for most people does not mess up their sleep. In fact, for some people, it helps their sleep because it's just enough to kind of chill our brains out. For some people, most people don't really notice much of a difference at all. But the amazing thing is it kicks in 10 hours later on its own. So if you take it at 8:30 at night, it's going to kick in at 6:30 in the morning, not you waking up at 6:30 in the morning, taking your breakfast, then taking your meds, then waiting another hour for your medicine to kick in. I don't know about you, but mornings are pretty fun around here. Please note my sarcasm. Okay. So that's one of the things that's really interesting about it. And the other thing that's great about it too is for folks who maybe get upset stomach with a lot of stimulants, they often don't have as much of a problem with this one. It also has a very much smoother, what we call absorption. So like if you look at the amount of medicine in the system, instead of going like this, like most of the other meds, it goes like this, and it has a much smoother tail. So I don't see as much side effects with this one. Typically, obviously everybody's different. And I do see kind of a smoother coming off of it for a lot of people. In theory, for a typical metabolizer, it's supposed to last 14 hours. So you would take it at 8:30, it would start at 6:30 and would last until the next dose at 8:30. So at least for typical metabolizers, this is kind of the closest we have to full day coverage with a stimulant medication, at least in a methylphenidate preparation. The other thing that's really great about it is it can be sprinkled. So for kids or adults or folks that just aren't great with swallowing pills or not a big fan of swallowing pills, it can be sprinkled and taken that way. So that's been a really interesting development in kind of the technology and formulations. Daytrana is another one that's kind of interesting because it's a patch. It's what we call a transdermal system. So you put it on the skin and it says it lasts for 9 hours. It can go a little longer. Okay. But what's nice about this one is that, again, you can kind of titrate a little bit easier how long it lasts. I had one mom years ago, this is before Jornay was an option, who would put would go into her son's room, put the Jornay, or excuse me, the Daytrana on his back, wait 30 minutes, and then go wake him up. Worked very, very well. The biggest challenge with Daytrana, frankly, is just availability and cost. Unfortunately, it's one of those ones that's kind of hard to get your hands on, and it's not always very well covered. But it can also be really good for those fast metabolizers. Folklin, I told you I was going to come back to this one, and I did. Here's what's interesting about Folklin, and this is going to come back at Vyvance too. But so Folklin is what we call dexmethylphenidate. What does that mean? Well, methylphenidate preparations are what we call a racemic mixture. What that means is there's two methylphenidate molecules. Essentially, they're mirror images of each other. We've got the right-handed one and the left-handed one. They're both methylphenidate. They're just mirror images. There was a theory that the dex, or the right-handed molecule, was responsible for all the good stuff, and the left-handed molecule, lefties always get a bad rap, the left-handed molecule was the one that was responsible for most of the side effects. So they created Folklin, where they took the left one out. That's your right, my left. Well, I'm whatever. They took the left-handed one out, and just left the right-handed. As with most things in science, that was theory. Theory did not completely apply clinically, but there are some folks for whom this medication works better and has fewer side effects. There's also folks for whom it doesn't work as well and or has more side effects. And it, again, like most of them, lasts about 10 to 12 hours and can be sprinkled. In general, in my personal experience, this is not based on data, like research data. This is based on my experience. I tend to wait on this one unless they failed a regular methylphenidate, and especially if there's concomitant anxiety or irritability or aggression. I find that this one has a little bit more risk of increasing those symptoms than the regular methylphenidate. Now, of course, that's not hard and fast. I definitely have some kids who struggle with those behaviors for whom Folklin has been really great. But it's just kind of something that I've noticed over the years, and talking to other ADHD professionals, they've noticed it as well. So here are I just wanted to include this to kind of give you an idea of the formulations that, like I've kind of mentioned before, are good for folks who maybe can't swallow pills or don't want to swallow pills. We now have chewable, we have oral dissolving, we have liquid, we have sprinkleable, we got options. Which I think is really, really awesome. And not just for our smaller kids, but there's plenty of adults who aren't fans of swallowing pills. Or one of the tricks that we'll do with the chewable or dissolvable or the liquid is, if you're struggling to find the right dose and one pill is too little and the next pill is too much, you can use a liquid or a or sometimes one of the chewables to cut and make a more specific dose for you. So that's one of the other little tricks there. Okay, so that was the methylphenidate. So now we're moving on to the amphetamines. The amphetamine class increases dopamine in the brain differently. It does it by actually increasing the release of dopamine from the neurons. So it actually gets your brain to push more dopamine out into that space between the brain cells so they can communicate better. So with the amphetamines, similar to the methylphenidates, a lot of the difference is in the formulation, how the medicine is delivered, how, when, all of that. But the other thing that varies between different formulations of amphetamines is the percentage of dexamphetamine to levoamphetamine, or what we call amphetamine salts. So just like in the methylphenidates, you've got that right-handed and left-handed, like I talked about, you've got that with the amphetamines too. And you don't see as much of a variation with the methylphenidates as you do with the amphetamines. And I'll talk about some details with some of the specific options and how that comes into play in just a second. Again, as I mentioned, you've got common side effects that can occur with any of the stimulants, but with the amphetamines, there is a little bit of an increased risk for decreased appetite, weight loss, irritability, increased anxiety, especially in young kids. So we actually don't recommend starting with an amphetamine, particularly in like elementary school age kids, because they're at higher risk for these side effects as well as the other side effects. The other thing that I see in the younger kids too, more with amphetamines and methylphenidates, Vyvance in particular, is things like skin picking or hair picking and those kinds of behaviors. So as with the methylphenidates, we have our short-acting immediate release and we have our long-acting. So our short-acting formulations also come in tabs as well as chewable, dissolvable, liquid, all the things. And similar to the immediate release methylphenidates, start kicking in about 30 minutes and last for about, the literature says 4 to 8 hours. I'm going to tell you in practice, I think it's less than that. I think it's more similar to the immediate release methylphenidate for most people. And again, just like with the methylphenidates, we prefer to use these as a booster dose or as a single agent only if long acting is not getting it done or isn't tolerated. And again, they have to be dosed at least 2, and frankly, for a lot of people, 3 times a day. Excuse me. The other issue with the amphetamine, particularly the short-acting amphetamines, short-acting amphetamine is the one with, frankly, the highest street value. This is the one that has the most risk for diversion, for use on college campuses, unfortunately, as a study drug or as a drug of abuse. Okay. Ooh. What's going on with my slides? There we go. Okay. So long acting, as I mentioned before, can vary by delivery system, but also by percentage of dexamphetamine. So in general, again, they kick in about between 20 and 60 minutes, also depending on your breakfast, as well as just you personally. Duration, depending on the formulation, anywhere from about 8 to 12 hours. Excuse me. Mydayis is the longest acting one at about 16 hours for average metabolizers. And again, like I said, with the methylphenidate long acting, you have the same issue with the amphetamine long acting, whereas for some people, they may have that increased emotional lability as the medication is wearing off. So the most, kind of common one, the one I think that everybody's the most familiar with is, of course, the, excuse me, that cough is kicking in, is the Adderall Xr, okay, or the extended release Adderall. So again, duration of action for this one can be 8 to 12 hours, depends on the person. The percentage of dexamphetamine in this one is 75%. And that's actually where a lot of the, other than Vyvance and Avikio, which I'll mention in a minute, most of your name brand amphetamine preparations are going to be about 75% dexamphetamine, 25% levo. This one does come in a generic, which definitely helps with availability and cost, and approximates, it's kind of similar to if you were to take the immediate release twice a day. Okay, that's what it kind of mimics. Okay, so Vyvance, that's one that, of course, their marketing people did a great job, I gotta say, because that is one that everybody seems to know about, right? So what Vyvance is and what makes it different is similar to the Folklin, it's just dexamphetamine, but it's a little bit different. It's lisdexamphetamine, which makes it a prodrug. What does that mean? Well, what it means is that they attach this little molecule, that little Liz molecule, to the dexamphetamine molecule. And that portion has to be cut off, has to be cleaved off the molecule before it can be absorbed into the system out of the gut. And that piece can only be cut off by an enzyme that is present in the gut. Great. Why does that matter? Because it decreases risk for abuse. Because to be frank, you can't crush it up and snort it. Well, you can, but it's not going to do anything. Okay, so that was a big reason why they did that. And that was a big reason why a lot of people were excited when it came out, because they were hoping this would help decrease diversion. The other thing that it actually does do, though, is it helps smooth out absorption. So while we do still see variation, depending on your own kind of metabolism of the medication, we don't see quite as much variation with it. It lasts usually about 12 plus hours for most people. Of course, for slow metabolizers, way longer. And for fast metabolizers, it can be, I've actually had a couple of kids who are such fast metabolizers, I had to twice a day dose Vyvance, which is impressive. It can, like I said, decrease risk for misuse. But one of the biggest issues with it is cost. It's been around long enough now that it's usually pretty well covered, but certainly it can be, if it's not, it can be a major cost issue. Now, good news is, I can't remember if it's, I think it's 2023. I don't think it's 2022, but within the next couple of years, we're coming up on the generic being able to come out. So that will hopefully help with availability and cost. Okay, so, oh, let me mention, I just realized I didn't have the Avikio on here. So just real quick, Avikio, which I mentioned earlier, is a preparation that is actually 50-50. It's 50% dex, 50% levo, and that's the main difference with it. I'll be honest, I don't use that one a whole lot because it doesn't last quite as long as the others. It typically ends up needing to be dosed at least twice a day. And I find that for most people, 50% dexamphetamine is not sufficient. But certainly if there's somebody for whom the amphetamine class works the best for them and they're really sensitive to the dexamphetamine, that might be a good option. Okay, now that was the stimulant medications. Non-stimulants. The main class of non-stimulants that we've really been using, we're starting to use more, we're learning more about, we're frankly getting a little even more excited about, is what we call the alpha-2 adrenergic agonists. Big long name. Basically, they are old school blood pressure medicines that, it's interesting because we say in the research, we say that we don't know how they work, technically how they work in ADHD, but how we know they work in managing blood pressure is by inhibiting sympathetic outflow. What does that mean? Fancy words for it tamps down the fight or flight response. They're literal chill pills, is what I've started to come to call them. Okay. But they literally calm the sympathetic nervous system. They calm the fight or flight response. And what they do for people with ADHD is they help with hyperactivity, impulsivity, irritability, aggression, sleep, emotional dysregulation. And now we're starting to see also improvement in rejection sensitivity. Seems like it makes sense to me, is all I'm going to say about that. What's really interesting about these medications is, again, the more we use them, the more we're learning about them. They have a low side effect profile. It's typically dizziness and sleepiness. But the downside is they are not as effective as the stimulants typically on their own for focus and attention. So that's part of why they haven't like overtaken the stimulants as like the #1 med, but they can come in really, really handy for working as an adjunct. And I'll get into that in a little bit more here. So the names of, again, these medications actually come in the long acting and shorter acting versions. The extended release options are what we typically use. The one most people have heard of is Intuitive, is the trade name. The generic name is Guanfazine. What it might show up on the script on your prescription is Guanfazine ER for extended release. And Clonidine, the trade name of which is Capvey. We haven't been using Capvey nearly as much. For one, it just doesn't seem to be quite as effective. Again, it seems to have to be dosed more. And for another, it's more expensive. Okay. The dosing is usually once daily in the morning, although I will say that for my patients for whom it maybe makes them a touch too sleepy, but it's really doing them a lot of good. Sometimes we'll move it to like the afternoon or the evening. The literature tells you it takes up to 2 to 3 full weeks to take full effect. And yes, maybe to get maximum effect, but I'm going to tell you, you see something pretty quickly. I mean, usually within 1 to 2 to 3 days, if you're going to see a response, you're starting to see something. The duration is really great. It's 12 to 24 hours is what the literature says, but for most people, we feel like they get pretty full day coverage. That's the other thing that's really great about these meds and possibly using them as an adjunct with the stimulant, okay? If you are a person or you have a child or the patient in question is somebody who, say, especially has challenges with emotional dysregulation and they're really struggling in the evening or the afternoon because their stimulants worn off. This is a place where a medicine like this could really come in handy. So as I mentioned, we typically use these as adjuncts to stimulants. We can, and sometimes we'll use them as single agent for either those who cannot tolerate a stimulant or have a contraindication, meaning a reason they can't take a stimulant. I will sometimes use it as a single agent if it's a kid who has, or a person who has ADHD that's largely or completely hyperactive impulsive type, but typically I'm using it as an adjunct. Excuse me. As I mentioned, side effects are mainly fatigue or sleepiness, dizziness. They list low blood pressure, but actually there's been some more research done that showed that, like, in a pretty good sized study, they didn't see any episodes of low blood pressure. So while we do watch that, it doesn't typically tend to be a huge issue. Downsides, like I said, less effective on its own than a stimulant. The other issue with the long-acting versions of these medications is they only come in tablet form that has to be swallowed. It cannot be crushed. It cannot be cut. So that can be a real downside if there's an issue with swallowing pills. Some of the kind of added benefits, though, this is actually first line for tics. So if you do have somebody who has tics or whose tics are exacerbated by their stimulant medication, this can be a really good choice. Sometimes we use these medications in conjunction with the stimulant to help if somebody can't get to an optimal dose of stimulant without hitting side effects. Sometimes these two together then helps them get that complete coverage. And sometimes I've found too that the Intuitive or the guanfacine in conjunction with the stimulant can sometimes counterbalance some of the side effects that somebody might have from their stimulant. So if there's somebody for whom the stimulant seems to be causing more jitteriness or increased anxiety or irritability, but if they go down on their stimulant, it's not effective enough, that might be a situation where guanfacine might be helpful. So the immediate release versions of clonidine and guanfacine also have some pretty fabulous uses. Duration is about 8 hours, but with the immediate release, they cause more sleepiness. So we don't tend to use them as much during the day, but these can actually be really, really helpful for people with ADHD who have difficulty initiating sleep, as we like to call it, or getting to sleep. Because these medicines actually address the core issue. They're not sleep medicines, right? But they address the core issue for us, which is the hyperarousal or the being too awake, not being able to flip the switch off. As I like to call it, the ADHD brain spin. This can help with that. So that's typically how we use them. But I have had kids who can't swallow pills for whom we feel like this could be a really good option. And we were able to use the immediate release and just crush it up. And for them, luckily, if it doesn't cause too much sleepiness or any sleepiness at all, we can use it during the day for those kids who can't swallow pills yet, or adults who can't swallow pills or don't want to swallow pills. One of the newest non-stimulants out there, this is now moving out of that class, the selective norepinephrine reuptake inhibitors have always kind of been an area of interest because they look at norepinephrine, that other neurotransmitter that I was talking about. They can increase the available norepinephrine in the brain. The newest one of these is called Qelbree, is the trade name. I'm not even going to try to say the generic. You can read it. This medication is fairly new to market. As I mentioned, it increases available norepinephrine in the brain. Dosing it's interesting. It's age-based. So ages 6, and it's available for 6 to 17. The adult approval, my understanding, is actually supposed to come out in March, potentially. But there's a set dosing based on age for what dose you start at and then what you can go up to. The onset, it's interesting because it's not as fast as the stimulants, but it doesn't take as long as your typical like antidepressant, which takes 4 to 6 weeks to take effect. Most people will start to have effect within about 1 week, but it can take up to 4 weeks to reach max effect. Benefits are it's not a controlled substance like the stimulants are, which of course can affect availability of the stimulants. It also provides 24-hour coverage, which of course the stimulants can't do. And of course, if there's somebody who can't tolerate a stimulant, doesn't want a stimulant, or can't take a stimulant for whatever reason, this could be a good option. I'll be honest, the literature, the research that first came out, which of course is done by the drug company, suggested that one of the things we were excited about was that it suggested that it could affect all core symptoms of ADHD. So as I mentioned, the alpha adrenergics, the guanfacine and the clonidine only affects certain core symptoms, the hyperactivity, impulsivity, et cetera, but not the focus and attention. The initial research suggests that this, at least in theory, can affect all those core symptoms as the stimulants do. In all honesty, I haven't used it a whole lot. Now, I haven't used it a whole lot because I have a hard time changing somebody who's on a gold standard medication to a not gold standard medication unless I have a really, really, really good reason to. But the other issue is, honestly, the kids I've tried it on, it hasn't been as effective and they've had side effects. Main side effects I've seen is sleepiness and appetite issues. Now, again, that's not to say that it couldn't be the right medication for the right person. I'm holding out my verdict until I see more data, is all I'm going to say about that. Okay. The other one that most people have kind of heard of is Strattera or atomoxetine. This is also an SNRI. Interestingly, Qelbree is trying to distance themselves from Strattera and say, yes, we're an SNRI, but we're very, very different. And the reason they're doing that is because most of us in the ADHD world are no longer using Strattera. And again, that does not say that if there's not people out there for whom this is a good medication, and if it's a medication that has worked for you, by all means, if it ain't broke, don't fix it. But the data really doesn't support the people for whom it works well for and is tolerated well by is a very small percentage. So in general, it's just not one of our go-tos anymore. From a dosing standpoint, though, it's weight-based, unlike, again, any of the other ones. And again, good things are it's not a controlled substance. It's once a day dosing. It has 24-hour coverage. Another downside too, though, is that it can take 6 to 8 weeks, up to even 12 weeks to reach full efficacy in folks who have trouble remembering to take their medicine every day. Personally, for me, that's a pretty big downside. Now, oh, I already mentioned this. So yes, again, like with the other non-stimulants, if we're using it at all, we're often using it as an adjunct. But the side effects, as I mentioned, well, the side effects, kind of similar to Qelbree, have also actually been a really big issue with this medicine: nausea, worsening mood, sleep disturbance, dry mouth, nervousness. And so with the side effects and lack of efficacy, it's like I said, it's really kind of fallen out of favor with a lot of us. So just to kind of briefly mention, I'm not going to go into details on any of these, but there are also other non-stimulant, kind of what we call third line options. Wellbutrin's a really interesting one. It's actually an antidepressant that's in a class all of its own, and it can help with ADHD. And again, for some people, if they can't tolerate a stimulant or in addition to a stimulant, especially if they do have coexisting depression, Wellbutrin can be a great option. Wellbutrin, interestingly, affects primarily dopamine with a soupçon of norepinephrine thrown in there. There's also a class of medications called tricyclic antidepressants that used to be used a lot more in the past than they are now, but they certainly can still be used, especially if there's coexisting depression or anxiety, or actually these are medicines we also use for migraines. So when I have somebody who has multiple issues, I always try to see how many birds I can hit with one stone. So just to kind of be aware of some of those other options. Okay, so we've talked about the meds. I'm keeping an eye on the time. Woo, okay. We have about 30 minutes left, is that right? Okay, so I'm gonna plow through some of this stuff pretty quickly because I do want to leave time for questions, okay? But just to kind of give you an idea, now that you have a little bit better understanding of the medicines, I often get asked, how do you even get started, right? And certainly finding a provider, as I think we probably all know, can be incredibly challenging. But I tell folks to start with your primary care provider. There are primary care providers like myself who are well-educated in ADHD. It's their jam, they're comfortable with it, and they're comfortable with doing the medications. So if they are, great, that makes it easy. If they're not, they typically can refer you to someone who can provide that care, whether it's a psychiatrist, developmental pediatrician, if it's a child, what have you. So with the AAP recommendations, I'm going to talk first on the kids. What we recommend once you find that provider is ages 4 to 6 is actually the only age group for which medication is not first line. Okay. The reason being that we found in the research that between ages 4 and 6, they have a higher risk for the side effects than the older kids. So first line for 4 to 6-year-olds is parent training behavioral management, which is a distinctive training program, and classroom interventions. But if that's not sufficient, if a child is really struggling, there is nothing wrong with starting a stimulant medication. But in that case, it's actually very, very specific. We recommend methylphenidate for the reasons I've already mentioned. For ages 6 to 12, first line is medication. It's medication, as well as parent training, behavioral management, and classroom interventions. For our 12 to 18-year-olds, it's still medication, but now we're moving more into like behavioral intervention for them, although I still think parent training is very valuable, as well as classroom accommodations, coaching. This is when coaching can really be very helpful for not just the parents, but for the kid, although I'm a big fan of coaching across the board. And then of course, for adults, medication, work accommodations, coaching, behavioral training, etc. Other things that we typically take into consideration, when we start these medications, it's unfortunately, as I tell my patients, my magic 8-ball is in the shop, right? It's honestly, it's an educated guess, because there is no, and I know there's a lot of stuff out there, there is no one brain scan, there is no one genetic test, there's no one thing that we can do to say this is the medicine that's going to work for you. We just have to try them, and we have to try, I tell my patients, we may have to try different medications, we may have to try different doses. This may be a process. We may hit it out of the park first try, but that's unlikely. Other things we take into consideration as we're trying to develop that educated guess are things like personal history. So if somebody does have a history of trying these medications, what's worked, what hasn't worked. Family history. Is there a family history of what's worked or hasn't worked? Coexisting conditions, as I mentioned before, like depression or anxiety, and of course, medical conditions, high blood pressure, heart disease, things like that. We don't know what'll work until we try, but we've got to try. And I tell people it can be a process, but it's a process. And I know this because I've been through it myself. It is worth it. It is worth it if you stick with it. And if you're able to find something that does work for you, it can be an absolute game changer. So as I mentioned before, we start low. Any of these medications, other than the ones that have kind of set kind of dosing, we start low and we titrate up slowly, until we reach the most effective dose. We can actually, for the stimulants, we can actually increase the dose every 3 to 5 days if it's being well tolerated. I typically tell my patients a week, just because that's easy to remember. And then they're changing the dose on a weekend or whenever they're not working or in school, so they can kind of test it out and see how they feel. But it's a lot of trial and error a lot of times. And it may take more time if we're having side effects and we have to kind of wait a little bit. In general, if the patients are having side effects, I tell them if they're mild and tolerable, try to stick with it for at least 2 weeks, taking it every day, because it can take every day, 2 weeks, 14 days to see what the side effects are going to do. After 2 weeks, pretty much what you see is what you're going to get, except for appetite, which can take a little bit longer. If the side effects are not tolerable, though, I tell them, call me. Okay. So, okay. I really want to get to the myths and misconceptions, but I really want you to have time to do questions. So I'm going to try again to kind of book through this a little bit. And again, I'm probably preaching to the choir here, but one of the ones that really, really drives me a little bit crazy, but it is very important to acknowledge, and it's one that I feel like I have to be very, very clear about, is that stimulant medication causes addiction. No. Categorical, no. In fact, the research shows us that when these medications are used properly and under the guidance of a medical provider in the dosages known to be of assistance and helpful and not beyond that, stimulants have a very low risk of dependence or addiction. And furthermore, as I mentioned earlier, proper treatment of our ADHD actually decreases our risk of drug use, drug abuse, and drug misuse. There was actually, when I was at the Aap Recommendations, which is the professional ADHD conference, a really fascinating study that showed that kids who were diagnosed young but not treated had the same increased risk for drug abuse as kids with ADHD who weren't diagnosed until adulthood. The ones who had a decreased risk of drug use and addiction were the ones who were not only diagnosed as children, but treated as children. And I wish I could show you the graph, because it was impressive. It was really impressive. And one of the biggest issues with this misconception is not only does it prevent people from seeking care or from getting care because they're concerned about these things, but it also makes it harder for those of us who really need these medications to get them because of the misconceptions, because of the limited availability, because of so many things. So that's one that I really get up on a soapbox about. This is another one that really drives me crazy, because I have actually had patients tell me that their doctor diagnosed them with ADHD, but said we should not treat them until their grades are going down. No, we should not be waiting for people to be in crisis before we start gold standard preventative medical treatment. We don't do that with anything else in medicine. We don't do that with anything else in pediatrics. I don't wait for an asthmatic to be on a ventilator in the ICU to start albuterol. I don't wait for a diabetic to be in the ICU in diabetic ketoacidosis to start insulin. So why would I wait for a kid to be in crisis to start gold standard treatment? I can guarantee you by the time it's outward, by the time they are failing or somebody is getting fired from work or their work stuff is suffering or relationships are suffering, we've been in crisis for a while. There is always a cost. I went to a private school. I had A's and B's when I was diagnosed with ADHD and a learning disability. It came at a cost. It came at a cost to my sleep. It came at a cost to anxiety. There's always a cost to what we have to do to mask or compensate if we're not getting appropriate treatment and support. That's another just big soapbox of mine. One of the last ones is that the medication is dangerous. Now, absolutely, I take these medications seriously. I take all medications seriously. I take everything we do in medicine seriously. Everything we do has risks and benefits. But the data shows us, long-term, substantial data shows us that these medications are largely safe and effective. The other big point, though, is there are side effects to not treating our ADHD. As I mentioned, increased risk of depression, anxiety, school failure, work failure, accidents, suicide, decreased life expectancy. So there are risks and benefits to the medications, but there are risks and benefits to not optimally treating our ADHD too, which I think is a really important thing for people to understand. Last but not least, my very last soapbox, and I promise I will answer questions. Shame. Anybody watch Game of Thrones? Shame. I just feel like I need my bell to ring. This is a big, big barrier to care. And I think it's something that most of us with ADHD, at least as adults, are very aware of. It's the other way I like to say is the should be able to's, right? I am a physician. I own my own practice. I have 2 children. I should be able to get out the door in time. I should be able to get my kids to school on time. I should be able to find my shoes after yelling at them for 30 minutes to find their shoes. I should be able to pay my bills on time. Whether we're an adult with ADHD or someone parenting a child with ADHD, we get hit with these social expectations of should be able to's, and this shame of if I turn to medication for myself, it's failure. It's a crutch. It means I couldn't do these basic adulting things on my own. If I am turning to medication for my child, it is because I have failed as a parent. No, we wouldn't not treat ourselves for another medical condition. We wouldn't not treat our children for another medical condition. But it is very real that that is how we feel and that is how we are made to feel. And again, it prevents people from seeking care. It is not failure. It is never failure to advocate for yourself or advocate for your child or advocate for your loved one for what you need, regardless of what that means, beyond just medications, whether that is accommodations, assistance, asking for help, or medication. It is never failure to advocate for what you need or what your child needs. And that is my final soapbox. So thank you all for sticking with me through all of that. I know that was a lot of information thrown at you, but I am happy to answer questions. And I know that went a little bit long, so I'm also happy to hang out a little bit later, especially since, sorry about that, we had some interruptions in the beginning. I think everybody's asleep now.
You're awesome. Thank you so much. That was so informative. And you packed so much in. Thank you so much. We got a lot of good questions. So I am going to, I think the first one I'm going to start with is, are there any concerns or studies that show that being on medication for your entire life, including when you're a senior citizen and stuff, are there any studies that show that it impacts, I lost my sheet, that it impacts, or is there a correlation between ADHD medication and neurocognitive diseases like Alzheimer's?
Interesting question. The best I can answer that is not to my knowledge. Of course, there's studies coming out every day, so I'm not going to say that that means it doesn't exist, but not to my knowledge. And in fact, okay, I don't want to say anything that I'm not absolutely positive on. I know there is some work, I think, being done in that area that actually may show the opposite, but don't quote me on that. I don't want to say something that's not, that I haven't read in a study. But no, we haven't, as far as I'm aware of, no. The other thing that's really interesting is while we do have more and more long-term data, right, on ADHD medication and ADHD medication through the lifespan, one of the challenges with those studies is we're studying ADHD people.
Right.
I don't care when you were diagnosed. Anybody here actually taken their medicine every single day since the moment they were diagnosed?
Right.
If you have, I want to meet you. Unless you were just diagnosed like 2 weeks ago. And then cool. But in all seriousness, the vast majority of us, even if we intend to stay on our medicine, and let's be honest, most of us take breaks from our medicine because we want to see if we can do it without, or we're just tired of taking it, or we're tired of the cost or whatever. But then there's also the, oopsie, I forgot to refill my meds.
Oh yeah.
Or I just keep forgetting, so I'm just going to stop for a hot minute, or what have you. So it is actually harder to study because of the population.
That totally makes sense.
But it's a great question.
And that actually brings us to another question about medication holidays. And so one of the two questions kept coming up. One about building a tolerance and
Yes.
How that works and what you have to do. And then the second question was about medication holidays and whether or not they're should we do them.
Thank you so much. And the reason I'm looking around is because you reminded me, I keep meaning to add tolerance to this talk and I keep forgetting. So I'm writing it down right now. So thank you for that question. Okay, I can't do two things at one time because I have ADHD. And the fact that people saying we can multitask is no, at least not me. Okay, so here's the deal. This is actually a really interesting question because this actually came up as a major topic of conversation during the last APSARD meeting, the last ADHD professionals meeting, because the wisdom of the age has been that we should take our medicine every single day because ADHD affects our lives every single day, right? We're starting to wonder about that because of the issue of building tolerance and how much of an issue is it? Here's what I've seen personally and in my clinic is not everybody builds tolerance. Some people have a real issue with it.
Yeah.
Some people, it's never an issue. Most of us are somewhere in between. So it really depends on the person. I actually happen to be one that really builds tolerance, and it's a wicked issue for me because I'm also incredibly sensitive to medications. Mm-hmm. So if I'm not careful, I build tolerance, but then I go up on a dose and then I can't tolerate that dose.
Yeah.
Fun. Yeah. So I actually do take scheduled breaks from mine. One of the things that's been challenging, and this is again was a topic of conversation, is we don't have data to suggest or to know how often should you take a break? How long should that break be? Is it just a weekend? Is it a day here and there? Does it need to be a full week? And if so, when? So I think it depends on one, if you're someone who builds tolerance and if that's an issue for you, but I think it also depends on how your ADHD affects your life, right? I have some patients for whom they do well from an emotional regulation standpoint. They do well with relationships. It's primarily focus and attention in school, right? Maybe it's a kid who's not driving yet. Maybe it's a kid who's actually shown themselves to be a pretty responsible driver, even off their medication. I worry about that though. Okay, well that kid, then I'm gonna feel a little bit more comfortable with them choosing not to take it on the weekends or not taking it over spring break or winter break. Not a huge fan of anybody taking the whole summer off, but some people will. If it's somebody who doesn't build a lot of tolerance or who really can't take a day off, okay, for their sake, for their relationship's sake, especially kiddos or adults who really struggle with the emotional dysregulation and impulsivity piece, then yeah, I'm going to suggest they take it every day. And if it's somebody who really needs it nearly every day but builds tolerance, well, then we got to really work as a team. We've got to be really thoughtful about when we do it, how we do it, what supports do they need,
Yeah.
and what supports are in place for when we choose to do that. The other issue is the dose of their medicine, because some people even at high doses can come on and off without a problem. But like if I have a kid who's on a higher dose of a stimulant and they decide to take the whole summer off, let's not go straight back to that high dose. You're not going to feel very good.
Yeah.
Right. So some of that comes into play too. It really is quite personal.
Do you ever find when people do take breaks and then start back that the medication doesn't work for them again, or does it usually still work for them?
I'm going to say typically it never works less well than it did when we stopped. Or I shouldn't say never, typically. But there is the situation where we took a break and we tried because it wasn't working as well, and we tried again and it's still not working as well.
Right.
And again, that comes back to the fact that we really don't know how long we need to take off or what factors for each individual might contribute to how long that particular person may need to take off.
Sure. It sounds like it's so complicated. We as patients find it really complicated, but as a doctor, it sounds like it's very complicated too. And it almost makes me wonder, I had heard that this year they were going to update the DSM with, and maybe there would be some new information about ADHD. And it just seems like one of the things that you stressed so many times in your presentation is how everybody, like, it's medications often are based on age or weight, and so it's all so subjective, and it's almost like those of us with ADHD are on some sort of spectrum ourselves because we don't all fit we're not easy.
No, we're not. And there's, the thing is there's definitely a lot of nuance to it. And the more as a provider, right, the more I do it, the more I kind of learn those nuances. But honestly, actually, I think a lot of it is educating my fellow providers, one, how to set expectations. Okay. Because I think that is a major thing. Like if you know this could take time, if there could be some hits or misses, if there could be side effects, but that doesn't mean you don't try another one, then you're going to be a lot more likely to stick with it. You're going to be less frustrated. Not saying that you might not get frustrated. Okay. But it's going to be a better process for you as a patient. So I think that's a big issue. But there's actually what I'm really hoping to see. We do have some standards in pediatrics and recommendations for pediatrics in how and what to start and when. They're getting there, I think, in the adult world. I don't know that they're there as much as we are in the pediatric world. And again, there's a level of nuance that you can't just put into a flow chart, right?
Sure.
But there is, to be perfectly honest, if it was up to me, I would teach pediatricians to start with a methylphenidate preparation in pretty much everybody, unless there's a significant family history to support the amphetamines, and start low and go up. Don't be afraid of it, right? And then if the first methylphenidate doesn't work, you try one or two others. And if that still doesn't work, then you go over to the amphetamines and you start with Adderall, not Vyvance. There is a lot to know. And there, like I said, there is some nuance, but there are also are ways to actually set up protocols that I think would really help streamline things for a lot of folks.
Yeah, if what you just described was the norm that I hear in our support groups, I would be so happy, but it's so all over the place. We had someone last week that said their doctor wouldn't prescribe Jornay because it was too new. And I think, gosh, I've heard about it for 3 years. So at least. So
well, and I gotta tell you, part of me feels like I got to be careful how vehemently I support Jornay. I do not get paid by them, but I'm so impressed by it that I'm like, But you know
I
what I
think-
mean? I have to be
yeah,
like,
I do.
I have to try not to be like, everyone should be on Jornay.
But frankly, as a parent, I don't think there are any of us that, you know, haven't asked our children's doctor that know about it. Yeah.
And here's the other thing about Jornay, I will also say, adults can take it too.
Yeah. Yeah. What a great thing for in the morning.
Oh my-
Okay, we have just a couple more questions.
Yes, ma'am.
There was one in particular talking about, you had mentioned the suicide rate and how it can be higher in people that are not neurotypical or have ADHD. And could you speak to that a little bit?
Yeah. Thank you, because I feel like, unfortunately, that's a topic that I don't typically get asked to speak about because people don't really want to talk about it. And so I kind of tend to, as you noticed, slip it into every talk I do because it needs to be talked about. Because we have a higher risk or rate of depression and anxiety, right? And other comorbid mental health challenges, you know, we're at increased risk for that reason. We're also at increased risk, again, for some of us with the emotional dysregulation and impulsivity challenges. The rejection sensitivity can play into that as well. But the other issue too is, I think, and again, this is now me not speaking out of like research, but speaking out of like experience doing this for a very long time with a lot of folks with ADHD. Again, the shame, you know, and while depression and anxiety, like genetically and neurochemically, seem to run along more frequently for folks with ADHD than other folks, we also know that untreated ADHD can lead to depression, can lead to anxiety, and certainly can exacerbate those things. I cannot tell you how many kids, girls in particular, who presented to me not for ADHD, presented to me for depression, anxiety, eating disorder, suicidality, self-harm. The underlying primary issue was ADHD. And when we treat their ADHD, I've had some kids where I never had to treat the depression or anxiety with an additional medication. I had one young lady who came to me with clear anxiety, depressed mood, anorexia nervosa with binge eating and purging. And the first day I met her, I'm like, you're a senior in high school. How have you not been diagnosed? I mean, it was so obvious. And we did try, she actually didn't tolerate the antidepressants. I started her on a stimulant. Her anxiety got better. Her depression her anxiety was worse in the evenings after her stimulant wore off.
Sure.
Right. So I think while there are definitely some situations where ADHD may get overdiagnosed, it's still vastly more of an issue of underdiagnosis, especially in girls and women. And so as a result, the ADHD goes untreated, then you end up with the depression and the anxiety and the sense of shame and the rejection sensitivity and the impulsivity.
Yeah.
And it's a tough combo.
It is. It is. So you mentioned that you know, other comorbidities like that, like eating disorders and things like that, which I know disordered eating can be also common with ADHD. And one of the questions that we had was, and I know you work with our younger population, but are you seeing a mix of people or starting to hear of people that have PTSD and ADHD or complex PTSD and ADHD? And if so, are there different medication combinations that work better for that population?
That is a great question. There's, again, that's a big area of research right now. That's a big area of discussion, is the intersection between trauma and ADHD. Because again, what we do know is folks with ADHD have a higher risk and higher rate of trauma.
Yes.
Now, why is that? Well, some of that is because of how we interact with the world and how the world interacts with us. Again, impulsivity, things like that can come into play. But of course, the other issue is it is highly genetic. So, and again, folks my age and older, I actually got diagnosed pretty young, which was kind of awesome in hindsight, but a lot of us didn't get diagnosed. So you're talking about also kids in families where there is oftentimes a significant prevalence of ADHD or other mental health issues that may or may not have been appropriately dealt with or gotten appropriate support, which then of course increases the risk for abuse, neglect, substance abuse, things like that. And in fact, when I'm seeing kids, I always ask parents, if anybody in the family is diagnosed with or suspected of having ADHD, learning disabilities, depression, anxiety, substance use issues, school issues, etc., because oftentimes they weren't diagnosed. But it's so funny because when I ask it that way, I almost always get an, oh yes,
Let me tell
my
you.
husband,
Yeah.
or my wife, or Uncle Joe, or, you know, whatever. But yeah, we do have higher risk of trauma. And one of the things that I think, and I've actually, my understanding is there is research being done on this. I don't know if there's, I haven't seen any published results, at least myself yet, but there's also the kind of interesting concept of, we know that like not everybody who goes through the same trauma is going to end up with PTSD, right? Or is going to have the same response. And so there's a lot of work right now just in PTSD in general, trying to figure out what are those risk factors, right? What are the, whether it's genetic factors or support, like what are the factors that put one person at higher risk for developing PTSD than another person? I don't know that we've for sure figured out that ADHD does, but it wouldn't surprise me. Again, one, because of just the already having difficulty with executive dysfunction and things like that, but also because we already know that folks with ADHD, depression, anxiety have higher risk of, for example, post-concussive syndrome, right? The brain chemistry is already tenuous at best, right? So we are more susceptible to neurologic insult, if you will, whether that is physical, you know, head trauma, infection, you know, or could it mean that we're also more susceptible to non-physical trauma to the brain, right?
Yeah.
I wouldn't be surprised if we were. As far as medications, no, there's not like a, like, oh, well, if you have PTSD and ADHD, you should do this. However, guanfacine.
And does that help with anxiety, or do you?
So it's not an anti-anxiety medication, but especially for folks that have ADHD and have, you know, especially like the physical symptoms of anxiety, right? Like increased heart rate, palpitations, you know, kind of panic attack type symptoms. Again, it literally decreases the body's response of that. So it would make sense that it would help with anxiety for a lot of people, especially people with ADHD. My kids, I have a cadre of kiddos with very similar symptomology of hyperactivity, impulsivity, focus and attention, serious mood dysregulation, like the explosive kids, the kids that melt down, right? The ones that sometimes get labeled disruptive mood disorder. Don't get me started on that diagnosis, and don't get me started on ODD, or we will be here all night. Don't use those terms. Those kids, I have a whole group. I actually probably need to write a paper on it, honestly, because I've got enough numbers now. All of them, you know, get labeled emotionally disturbed. It's anxiety and ADHD and methylphenidate and guanfacine.
Okay.
I tell you what. And I've had a few of those kids that do then still end up needing something else like an SSRI or Buspar or something for their anxiety. But a fair number of those kids don't.
That's great.
And when we treat their ADHD and we help them with their impulsivity and we help them with their emotional dysregulation, oh, shocker, they're not melting down.
That's
And
great.
oh, by the way, when we teach the people around them, do not touch the child who goes into fight mode when they're in fight mode.
Oh, yeah.
Please don't do that. Do not corner them. Do not touch them.
They already don't feel
They
safe.
will fight back.
Yeah.
You, by the way, I have to say this, you wouldn't do that to an adult who is angry.
No.
So why do we think that's a good idea to do to a child? Sorry, soapbox.
No, it's
A lot of
wonderful.
soapboxes.
But I agree with you 100%. So I'm going to ask this question, even though I think I already know the answer to it. I'm going to ask it in my own way. If someone is prescribed Wellbutrin as an adult for the symptoms of ADHD, don't they need to find a new doctor?
Sorry, say that again.
If someone is prescribed Wellbutrin as a first line, and there's no health reasons for that or whatever, as a first line as an adult, should they try to find another doctor? Or is there maybe a reason for that, why someone might start with that?
Can I plead the fifth? No, I mean, honestly, you can't take every single situation, right? As we've discussed, right? There's so much nuance.
Yeah, no, and this was asked by like 3 or 4 different people.
Yeah,
So,
yeah. So
that's broad.
Here's what I will say. And this is really honestly something that I've become very passionate about is teaching my fellow providers. And I'm actually in faculty at one of the med schools here because I want to teach the up and coming kids. Kids, oh God, I'm old. Anyway, actually just figured out just how long it's been since I graduated, and that was a moment. But anywho, no, I think there is a lot of lack of comfort with these medications, especially with adult physicians, because they're not trained on it.
Yeah.
Right. And you don't want your doctor prescribing or managing something they're not familiar with or they're not comfortable with. Right. So sometimes that is the issue at play, but sometimes maybe they feel like, maybe there's been a family history where Wellbutrin worked, or maybe they feel like you need more full day coverage, or maybe they see that there's a significant depression component. So, hey, let's try this one first. And if it happens to kill 2 birds with 1 stone, great. If it doesn't, okay, let's circle back around. So it's hard for me to say that you should find another physician. But if you feel like that's not the right medicine for you, and you feel like that you need something else, you need to talk with your provider. If your provider is not receptive, if you don't feel like you have the trust relationship that you need with your provider, no matter who they are, then you do need to find somebody else, because regardless of what their comfort level is, regardless of how good they are, if you don't have the relationship you need to have with them, you're not going to get what you need, right? So that's kind of my general rule of thumb. And I think, the other thing too that I really want patients to kind of all ages, I want everybody to kind of understand is there are a lot of doctors out there. There is more education that is needed. Like I said, there's obviously a lot of information, a lot of nuance, but doctors are in crisis right now. We are in absolute crisis. Even before the pandemic, and the pandemic just made it worse. My colleagues, typically, if they're in a large health system or a large group, they have zero control over their schedule. They have zero control over their staff. They have zero control over the amount of time they get to spend in an appointment. And most primary care docs are being limited to about 15 to 20 minutes per visit. If they see less than 30 patients a day, they're told they're not seeing enough. So what I've seen from some of my colleagues is not that they don't want to do this. It's not that they don't want to do it right. It's not that they don't care. It's that they don't feel like they have the time to do it right. And if they can't do it right, they're not going to do it at all. Mm-hmm. Now, I have various feelings on that, because then, of course, it still leaves patients without care. And that in and of itself, obviously, is a massive challenge. But the other thing a lot of people don't understand is docs are actually, they get roped into these contracts with non-competes that they can't get out of.
Oh, at the clinic they
Yeah.
work at?
Yeah. So for example, at one point in time, I had a non-compete that was 2 years and 50 miles. Luckily, I was moving out of state. My husband had to hire a lawyer to get him released from a contract where he was on a 2-year non-compete within 50 miles or a $400,000 buyout. So they're literally trapped. I do what I do the way I do because I was able to get out and I was able to open my own clinic, but not everybody is in that position.
Right.
And that's really where a lot of this crisis honestly is coming from, to be perfectly honest. And people don't know that.
No,
You know?
I mean, I think you're right. I think most people don't understand that's what's going on. Thank you for explaining it.
Yeah.
I really appreciate you sticking with us for a little bit longer. I'm going to actually wrap us up with our last question, which is about genetic testing and how in your practice, do you find it helpful for ADHD and anxiety and other, medication prescribing? Do you find it helpful?
That's a great question. Honestly, for ADHD meds, no. And I'll explain in a sec. We do use gene site testing in my clinic. I don't do it for everybody. It is not a magic bullet. Like most things, I take a middle of the road approach. No, it is not the magic bullet that should be done on everybody, but it is also not evil with no value. Okay. It is mostly valuable for the SSRIs or, antidepressant, anti-anxiety medications because, and in people for whom they have struggled to find the right thing, or they're sensitive to side effects, or there's a family history of that. Okay. When we get these reports back, we get 3 columns for each of these classes of medications. We get the red one, the yellow one, and the green one. Red zone says, hey, this medicine based on genetics alone is either more likely to cause side effects or more likely to be less effective. Green zone means we don't see any genetic issues with it. Yellow zone means might be less effective, might be higher risk for side effects. Where I can sometimes see value in it too, though, is it gives me footnotes that tell me why, right? So it might tell me this person might need a higher dose. This person might need a lower dose. The SSRI that I was thinking about might be less effective. So maybe I'll try this one first. And because those medicines take 4 to 6 weeks on each dose to reach full effect, that's a situation where that information could significantly decrease the amount of time and money it takes for us to get to the right medication. It's not perfect though. I've had these reports come back where everything's in the green zone. Okay. I've had it come back where everything's in the red zone. Awesome. I've had them come back where we're like, well, that's great. That's basically everything we just saw clinically, but it doesn't give us additional information. Or I've had them come back where it's like, really? Because the one that's working is in the red zone and the one that didn't work or gave you side effects is in your green zone. Okay, great. Because we don't have all the genetic markers, and genetics isn't everything, right? Age, hormones, other environmental factors also come into play. The reason why I don't find it to be as helpful with the ADHD meds, sometimes it's interesting, right? Because it'll come back and it'll be like, oh, this person has a mutation in the COMT gene or whatever, right? Which is one of the receptors that the meds work on. And you can go, oh, yeah, okay, that makes sense, right? That makes sense with what we saw. The ADHD meds work so fast that testing doesn't tell me anything that I can't figure out relatively quickly with relatively few doses and family history.
Yeah.
So I'm not against it, especially if there's somebody who's really struggling to find the right thing for them or doesn't have a lot of, family history to go on. But they haven't been shown to be as helpful for the ADHD meds. And actually, speaking of genetics, if I may, the gentleman who keeps giggling and laughing at me over there by the name of James Lynch would be my brother. So he lives in LA, and literally right before I came on, I was like, oh crap, I forgot to tell Jay I was doing this. Sorry, James.
That's one way to have a family reunion.
And so I was texting him, I was like, dude, I'm getting ready to do this thing. So yes,
Okay,
so I'm watching his face because he keeps laughing at me.
I love it. I have two, and I'm thinking, what a great sibling relationship. That's so fantastic. I have one more question I'm going to ask because I think it's quick and it's specific. If someone has fatty liver, how might that affect the way, since the medication is metabolized
Processed in the liver.
How might that affect their dosage?
Again, that's going to be a very it's going to be a very individual situation. And it depends on the extent of the fatty liver disease and what liver enzymes are being directly affected by it, right? In theory, it's possible, especially if it's mild, that it doesn't have much of an effect and the dosage doesn't change. But if there's significant hepatic, liver impairment, then the likelihood is you're going to have to come down on the dose because it means you're not going to be producing as much of the enzymes that process the medicine, which means it's going to stay in your system longer at higher doses.
Okay.
Or I mean, at higher levels, excuse me,
Okay.
that's what I mean by that. But again, it's a very individual thing. Yeah.
Oh, thank you so much for being here. I could talk to you about this stuff for hours. I really, really appreciate your wisdom tonight and your humor and you bringing your family. Thank you so much. And I want to thank everybody else for being here as well. I'm going to throw up just to show you guys. Let me see if I can share my screen. I'm going to show you what we have coming up. So in addition to tonight's education meeting, we also have our young women and our adult groups on Sundays. And then the first Friday of the month, we have our parenting ADHD meeting, which is a support group for parents. And then next month, we will, some of you know our board member, Yulia, and she will be doing a workshop on quieting your inner critic and negative self-talk. So I hope you'll come back and join us next month for that. And if you guys have any questions, I will stay on a little bit longer in case they're not related to medication and stuff like that, and you just have questions about our group or whatever. So thank you guys all for coming. And thank you again so much, Carolyn. I look forward to seeing you on our next call for the conference.
Absolutely. Oh, speaking of which, real quick, I got to put a plug in for the conference.
Okay, do it.
The International Conference on ADHD, God willing, COVID willing, it will be in Dallas this year. Yay, my stomping grounds. We're probably going to do a hybrid situation as well, but I highly recommend coming in person. It is 3 of the most soul affirming days.
Yeah,
it's one of the only places where I can go and be respected as a professional while skipping down the hallway and swing dancing with my friends. So I really do recommend coming. It is not only for professionals, it is also for adults and parents and anybody and everybody who has ADHD or loves someone with ADHD. There's a lot of really great programming. I cannot say enough about it.
Yeah, there's a lot of great education, but it's also just amazing to meet other people with ADHD. I mean, it's like not having to apologize for needing to take a time out in your room to like recharge, not having to apologize for being late. Fantastic. Thank you so much. Thank you for being here.